abdominal pain on physician perspective. Okay, most of the time the abdominal pain is due to, as we understand, the surgical causes. But there are some situations in which we'll find that it is not really surgical related. It is more like it's non-surgical causes of abdominal pain. So what we describe here as a medical cause of abdominal pain. Medical cause of this abdominal pain sometimes can be around like 5% of the presentation. I mean, as overall, the abdominal pain is about 5% of the emergency admissions. And it could either be something which is very acute, which is life-threatening, requiring emergency or urgent surgical intervention, or it could also be some kind of a non-surgical causes. The commonest thing that we learn from during our medical student years would be like diabetic ketoacidosis, or it could be a renal colicky pain because of the pelvic or pelvic stones, okay, and also acute problems of chronic diseases. Okay, what I'm going to show here is that we know that in some situations that the abdominal pain comes on the various parts of our abdomen, and it can really be related to from the peritoneal cavity, retroperitoneum, pelvis, abdominal wall, or even outside the abdomen. Sometimes it can be very tricky, sometimes it can be very straightforward, but time is the essence. Most of the time, if we are late in making the diagnosis, there will be some issues, the complications that we have to encounter along the way. Pain receptors in abdomens is actually stimulated by mechanical or even chemical stimuli. The mechanical pain here is referred by the stimulation by mechanical pain is referring to some kind of a compression. Either it's external or it could be sometimes internally. And with regards of the primary mechanical stimulus, most of the time it's because of the stretching effect, in which sometimes patient describes as colicky or spasmodic pain. And if you look at the visceral mucosal receptors, this is most of the time is due to the chemical stimuli. So this is what I'm referring to, the intraluminal receptors, which is commonly due to the drug induced. So this can be stimulating the nerve ending receptors intraluminally in the visceral mucosa. Visceral pain localization is a bit tricky. It is ill-defined and it's of the type and the density of the afferent nerves in the viscera. And most of the time, patient complains the pain in the midline. And this is mainly because the afferent nerves, the receptors, is present and it is being supplied from both sides of the spinal cord. So that gives rise to some kind of confusing part that we perceive that it is actually in midline, but in actual fact, it is not really there. Lateralized pain may arise from the ipsilateral kidney, ureter, ovary. This is quite straightforward. Like for example, if we do a renal punch test examination to our patient, that will tell us exactly which kidney is involved. So that would be a very quite a straightforward way of diagnosing the conditions. Okay, this is what is happening now. Even during our medical student years, we know that in terms of our approach in any medical conditions, thorough history is about 75%, which is very, very important, getting a good history, which is talking about the nature of the pain, the aggravating factors, the relieving factors, and when it starts, the chronicity, the frequency, those kind of things. And complete physical examination covers about 10% of whatever that we got from the history. We tend to go directly to where is the organ involvement, which is most likely causing the cause of the abdominal pain. And the relevant investigation, which can comprise about 15%, depending on the sensitivity and the specificity of the test. I just want to highlight in some situations in which that you may have some kind of a vasculitic lesions in which you cannot do radiological investigations like a normal plain angio. We may have to do something more extra, and people will be considering whether it's arterial or it's venous phase, and CT angio may be indicated. In fact, to some extent, we have to go further. And of course, after that, it will be followed by initial management. This is what we had. This is what we have been taught. This is what happens for the last few years. But now, unfortunately, we are kind of, I would say that we are a little bit, in a way, we are disabled. We are unable to do a complete physical examination because our time of contact with our patient has always been limited, despite the point that we have to use PPEs, taking all the precautions. Our complete physical examination now comprises only 5% of what we can do with the patient. And thorough history now becomes the main point that we have to gather from the patient. And of course, now the relevant investigations has to be further done as what we have done before this. This is what happens actually. This is what we gather. In fact, now what is being proposed, the less contact with the potential, anyone is a suspect now, COVID. So especially when we are seeing this patient in our consultation room, we are concerned with the exposure time that we had. Anything more than 15%, 50 minutes, we are likely high risk of contracting COVID infection. So this is very much important for us to understand that we have to be we have to change the way how we approach things nowadays.